So, good evening, everyone. Welcoming you all to the infectious diseases module, basic module in infectious diseases, presentation 3. So, cycle 2. So, myself, I am Dr. Swati Samban. So, I am infectious diseases forum member, and the topic for today is a dilemma for most of the clinical pharmacists out there. And the topic is antimicrobial dosing in patients on renal replacement therapy, which I know will be a nightmare for most of the clinical pharmacists out there. So, and introducing you all to the presenter of So it's indeed my pleasure to welcome Dr. Grace Mary John. So ma'am is the first in the only board certified clinical infectious diseases pharmacist. She's a pioneer in showcasing the model of ID trained pharmacist led antimicrobial stewardship program in India. She has been the international ambassador, the Society of Healthcare Epidemiology of America, that's SHIA, and the board of Pharmacy Specialist BPS. So Matt is currently employed in Believers Church Medical College, assistant director there, infectious diseases clinical pharmacy specialist, head department of clinical pharmacy, assistant professor, department of pharmacology for MBBS students. Ma'am is also the president of Federation of Clinical Pharmacists of India, or FCPI, and a journal reviewer of PLOS Global Public Health. Welcoming you, madam.
Thank you, Swati. Swati, for the presentation, there are some guidelines that the participants needs to know. So I'll share the slides. You can say the contents for that also.
Yes, ma'am. Yes. Yes. Moving on with the participant guidelines. The participant guidelines, so you can type your questions or responses in the comment box and click the submit button. Your questions will be discussed during the Q&A session that will be towards the end of the session after the presentations. So you can submit your feedback. So the feedback button will be available below the comment box, and the feedback form will be disabled once the live session will be over. And you can claim your certificate. So certificates, once you have submitted your feedback, the certificates will be available within 14 days after attending the event. So if you are watching it live on YouTube, it's mandatory that you should be registered to the FCPI. And now you can download your slides while with your login credentials. You can download the slides towards the end of the presentation. Over to you, ma'am. Yeah.
Thank you, Swati, for the introduction. So like most of you know that we usually struggle a lot when it comes to renal dosing. There are no specific guidelines as to how to dose antimicrobials, especially in the ICU setting. Many different centers do it differently. And I am here to talk to you regarding what are the principles that are behind the renal replacement therapy and regarding the antimicrobial dosing. I do not have any conflicts for this presentation. I do not have any disclosures. So during this presentation, I'll be talking about, like I said, the concept, the purpose of renal replacement therapy, the fundamental principles for various modalities of renal replacement therapy, the types of renal replacement therapy, especially the IHT, the SLED, the continuous renal replacement therapy, and the principles when it comes to drug dosing, and a small window into how you can utilize your skills as a clinical pharmacist in helping to dose patients on antimicrobials when it comes to renal replacement therapy. So diving into this presentation, we've all learned that kidney functions as the filtration system, as a filter for the human body, and there are three kidney functions. I mean, the three key functions that the kidney performs. One is the ultrafiltration, where the filtration really happens in the glomerulus, and then the excretion and reabsorption, or secretion and the reabsorption, which happens in the tubules. Some are secreted and some are reabsorbed back into the system. So these three major things becomes the core components when it comes to how the kidney functions, how nephron functions, and this has been our basics, and we've been studying this for a long time. And let me just dive right into as to what are the indications for doing a renal replacement therapy. So we know that the first thing that comes to our mind when you hear RRT, or renal replacement therapy, is hemodialysis. Patients on CKD having hemodialysis. But there are various indications for which RRT is being used. And to list some, the renal ones that we know, like the CKD stage 5, who can't be, whose kidneys, both the kidneys are literally not working. So you give the renal replacement therapy as, a salvage therapy to make them, move on with their lives by adding a filter, from the from outside. That is the major one that we all know. But there are other things as well, like whenever there is a rapid rise in urea, creatinine, and it can be because of, it can be part of a multi-organ dysfunction. It can be some other kidney insult that can happen. It can be pre-renal, renal, post-renal. And we have also, when a patient is hyperkalemic, coming to you and not responding to the usual standards of therapy as the initial medical management that we give. If the patient is not responding, we know that it can lead to arrhythmia and even death. Therefore, unresponsive or unresponsive hyperkalemia can be one of the reasons for which RRT can be initiated. And obviously, when the kidney shut down, there's a lot of acid that comes and accumulates and causing severe metabolic acidosis. And during the metabolic acidosis, the whole body goes into haywire, and therefore, one of the major reasons why to immediately reverse that situation of acidosis is one reason why we usually start the RRT. And obviously, whenever it is not, whenever a patient is having CHF, CKD with pulmonary edema, and they are not responding to diuretics, the high dose loop diuretics that we are giving, whatever therapy we are medically management, whatever we are giving, it's not being effective. That is one way, one indication where we would like to start RRT. And obviously, when the kidney is not producing enough urine and there's a lot of fluid accumulation, which can later lead on to a lot of other complications like pulmonary edema. So these are the renal related indications that can happen. And there are certain non-renal indications for which RRT can be started, like, the fluid imbalance. It might not be the renal one, it could be the cardiac failure. And it could be just to get rid of the toxins because of some ingested toxins that had happened, or electrolyte corrections not related to the CKD part of it, but some other reasons. And also, an important one is to make sure the temperature in the body stays, within the limits of of letting the body to do the normal physiology. And obviously, when it comes to modes, there are so much inflammation, so many inflammatory mediators in sepsis. So that is the other one which we can do an RRT. Now, in this presentation, I'll be mostly concentrating on the acute kidney injury in ICU, and RRT specifically more towards in the critical care setting. All right. So why is it important? Because nearly or more than half of the patients admitted to the ICU, they tend to have some degree of acute kidney injury, and out of them, 70% would require, renal replacement therapy for the aforementioned reasons. And you know that once a patient goes into an RRT because of an AKI, the mortality goes up considerably high. 50 to 60% mortality is already there. And when it is when it is an AKI because of sepsis or septic shock and multi-organ dysfunction, the mortality even goes higher. So AKI is a real problem when it comes to the critical care setting. And the dosing recommendations, the dilemma that we have at hand is that the dosing recommendations for continuous renal replacement is available only for less than 20% of the drugs. I'm not talking about antibiotics, but 20% of the drugs overall. We don't have much data about those drugs. 80% of the drugs, we still don't know what is the best dose to give. But maybe with this presentation, you know how to choose drugs, which drugs to dose, which drugs we do not consider to dose during CRRT. And when it comes to hybrid methods like SLED, even lesser number or even lesser guidelines are there for lesser number of drugs. So all these things are the reason why we clinical pharmacists need to know how to take control of the pharmacokinetics, the pharmacodynamics, and how to dose your patient in the right way. So, coming to acute kidney injury, you know that acute kidney injury can be classified based on two things. It can be urine output, it can be creatinine. So, both of these parameters are the cornerstones when it comes to diagnosing a patient with acute kidney injury. And urine output remains, one of the cornerstones. But there are, as you can see in the slide, three major categories. I'm sure those working in the critical care would have heard about these three types of classifications when it comes to acute kidney injury. You have the KDIGO staging, you have the Akin staging, and you have the Rifle criteria. So I just want everyone to, especially the students who are listening, I want you to look at how bad when it is coming to the third stage. So when your kidney is not producing 0.3 ml per kg per hour for 24 hours, or if the patient goes into anuria, there is not even a single drop of urine is being produced by the patient for more than 12 hours. That is when the patient is quite very sick. And if you look at all throughout these three classifications, you can see throughout that in stage 3 is where you usually see the term RRT, or the time to start RRT. Like I said, we are not going to talk about the renal dosing in chronic kidney diseases because most of the guidelines are already laid. But it is more important that we dose the patient for acute kidney injury because the physiology is very different. The CKD is thrice weekly intermittent dialysis that usually happens, or the peritoneal dialysis. And like I said, so many guidelines are already there. But our job is to make sure when it comes to an acute event, we have to dose them rightly. So if you know these concepts well, you can even dose your patients in CKD even as a better expert than before. So like I said, the more important thing is that when the kidney is not producing urine or very less urine in the past 24 hours, that's when you think of whether to take the patient for dialysis or not. Okay. And like I said, I use the word dialysis right now. So dialysis, is it interchangeable with RRT? I'll come to that in the classifications and the modalities. It's for the easier understanding that I'm using this term interchangeably. Okay. Now the problem with dosing in acute kidney injury, it's a double-edged sword because you have a tendency that, if you dose these patients, they can get underdose because you're adjusting the dose. And there's a good category of patient who falls into this underdosing. And but if you do it without caution, you can even end up having the patient intoxicated because of the drug effects. Okay, so that's why the dosing comes like a double-edged sword. We need to find the middle ground between these two. We should dose the patient, and like we always say, optimize the dosing based on the patient condition. Now, coming to renal replacement therapy, I said I used the word dialysis earlier in the one of the previous slides. And this is dialysis. This is what is known as dialysis. So you know the basic principle that is underlying the hemodialysis. Okay, so you have a filter outside. You have the hemodialyzer outside, and it has lot of tubes running in. Lot of tubes running in, and typically, a patient on a CKD, let's talk about CKD for the bit right now for understanding this principle. So you see a patient lying there, a cartoon of a patient lying there very comfortably, and it takes usually 3 to 4 hours of sessions to make sure this the fluid accumulated because of the kidney failure is removed, the electrolytes are balanced, and this is what usually happens. And as you can see, this is the hemodialyzer, and you have your vein and your artery. So from the vein, like we always say, the impure blood goes to the dialyzer, and in the dialyzer unit, this hemodialysis happens. And then from the dialyzer, the pure blood is given back to the artery. And now we know that patients who are having ISD, they have something called as the AV fistula. So in patients with long-term intermittent dialysis, who are requiring long-term intermittent dialysis, they'll need a permanent vascular access, which is optimally usually called as, the AV fistula, where more volume of blood can be taken all at once and can be given to the patient. So this is how it is usually done, and this is like the pure basic when it comes to how, you're taking the blood, putting it in a filter, and giving back the filtered good blood is the principle. Now I'll come to the more deeper meanings of hemodialysis, the principles. So before that, what are the types of hemodialysis, or what are the types of renal replacement therapy we have at hand? So I know this is quite a busy slide, and this can, earlier when I used to see the slide as a student, I used to tear my hair apart because it seemed quite complex. So first, I want you to concentrate on the left side, that is the intermittent dialysis. Just go through the terms that are written here with me. So the intermittent part, the intermittent ways of doing renal replacement, you have intermittent dialysis, you have isolated ultrafiltration. Okay, so you have IHD and IUF, hemodialysis and ultrafiltration. Then come straight to the red columns that are the continuous, instead of giving it 3 to 4 hours, you do it continuously for 24 hours. That is giving, using the filter for continuous 24 hours. So you have many different things here. I know it can be extremely confusing, but if you learn the basics, it is so simple to understand what each one does just with the name of it. Okay, so you have continuous venous hemofiltration, you have continuous veno-venous hemodialysis, you have continuous veno-veno hemodiafiltration, and you have slow continuous ultrafiltration. Okay, and I hope you understood the enunciations that I made there. So you have hemofiltration, you have ultrafiltration, you have hemodialysis, and you have a mixture of hemodiafiltration. Okay, so these are the principles that will differ, and I'll be explaining them to you in the coming slides. And in patients where, in the patients who can't, be put on a continuous renal replacement therapy, but they can't be put on the intermittent replacement. We have something, a hybrid therapy, wherein instead of 3 to 4 hours, we might do it for 6 hours or 8 hours or up to 12 hours. So this is called the SLED, that is a sustained or slow, low efficiency dialysis. That is SLED, and you have filtration also in that, and it is alternatively called as the PI-RRRT. Okay, so these are the various types, and in my presentation, I have not touched peritoneal dialysis because that is out of the scope for this presentation. This is to understand the principles when it comes to the ICU setting. So I have not included peritoneal dialysis in this presentation. And what I'm going to today for this presentation highlight are the three ones in star: the intermittent hemodialysis, the SLED, and the continuous veno-venous hemodiafiltration. Okay. Now, like I said, I know the terms can be quite confusing, but let me come to the terms why they are called dialysis, filtration, filtration, all these things. So, usually, you know that the basic principle of RRT is based on diffusion, the principle of diffusion. That means you have two compartments separated by a semi-permeable membrane. Okay, in that semi-permeable membrane, the small molecules can pass through from a high concentration to a low concentration. So here, the blood is your highly concentrated compartment. And when you run it through the filter, in the filter, there is the dialysate. Okay, so the blood runs through capillaries which are bathed in dialysate fluid. Okay, so the dialysate will have less amount of fluid, less amount of solutes, the less concentrated ones. So when the blood flows through this dialysate, slowly the diffusion happens. So from the high concentration to the low concentration, whatever is permeable, which are the small molecules, the small sized molecules will pass through the semi-permeable membrane when the blood passes through this. So this is your semi-permeable membrane. This is the blood and the dialysate, and you can see that the large molecules do not pass. Only the small molecules, because of the concentration gradient, they from the high concentration they go to the low concentration. So this is the basics of renal replacement therapy. So this is diffusion. Okay, so this is a very clear concept for all of us. We have studied it in many different ways in many different subjects. So this is the cornerstone. And now let me come to the next term that is called as the ultrafiltration. All right. So you see here the ultrafiltration. Again, two compartments where it is separated by a semi-permeable membrane. But here, what you don't see when you compare it with the diffusion are these solutes. So the small particles that comes from the high concentration to the low concentration, it is not here. And the additional thing that you see in ultrafiltration are these three arrows. Okay. So basically, what this means is that the blood flows in a certain pressure. But in ultrafiltration, you give extra fluid to increase the pressure gradient. So you put pressure in this compartment with the blood that is flowing through the dialyzer unit. In this one, because of the pressure, only the fluid is being filtered. Okay, I'm using the word filtered because it is ultrafiltration. It's easier for you to remember. In ultrafiltration, there's only filtering. There is no diffusion. There is no solute movement from one place to the next, from the high concentration to the low concentration. So you put a pressure to the blood that is flowing through the unit. And because of that pressure, the fluid just goes into the next compartment, and that becomes your ultrafiltrate. Okay, so now you know the difference between diffusion and the difference between ultrafiltration. Okay, now the third and the most important one is the principle called convection, where it is a combination of diffusion and ultrafiltration. Okay, so here it's quite simple. You put the pressure, and the solutes also go from this area to this area, and the semi-permeable membrane can be a bit more porous. So you can see some of the bigger molecules also going to the other side. So the movement of the solute with the water flow due to the solvent drag is so basically combination of diffusion and ultrafiltration leads to convection. But in convection, when you compare with diffusion, some of the large molecules also pass. Not everything, but some of the large molecules also will, because of the pressure, will go from the high concentration to the low concentration. So if you understand this concept behind RRT, things become so much easier. So if I come back, let me just come back for the sake of it. Now you look at these terms, it's easy. You know that where does It's where does it mean to only take off the excess fluid, like in pulmonary edema? It's only the fluid that is worrying for the clinician. So in pulmonary edema, you can do this scuff or your isolated ultrafiltration, all these things. But if you're really worried about, the hyperkalemia or all the other electrolyte related imbalances, you have to go for a hemodiafiltration or a hemodialysis kind of thing rather than just the ultrafiltration. So now the terms becomes more clear. So uh, coming back to that point, so convection is that part where it's a combination of both diffusion and ultrafiltration. Now I have a very interesting video from YouTube for you to understand this even better. So this is the hemodialysis kinetics O1, the method of convection. So here you can see that, so this is I'll again show, this is, so the red one is the blood, okay? And this is your dialysate. So you can see it is equal now, but you can see here two, you know, uh, gauges. So it's a pressure gauges. You can see that the pressure in the blue compartment or the dialysate is on the lower side. But the pressure here in the blood compartment where the blood is flowing, it is higher, okay? So this is separated by the semi-permeable membrane. So this is convection. I'm only talking about convection here. So let me play this video. So in this convection, you can see this. Okay, you have the small molecules, you have the medium-sized molecules, and you have the large molecule like albumin. In convection, so again, I will stop the video here. You can see the water goes to the other compartment. The small molecules also, the small molecules along with the medium-sized molecules, they pass through this semi-permeable membrane. But the large molecules like albumin will keep staying back in your blood compartment. So this is convection. So you can see it was when it started, the concentration or the level of fluid was equal in both. But as you flow this, as you lead, as you make the blood flow through this filter, more water goes out along with some solutes of small to medium size, that you can see the size that I mentioned here also. The creatinine also is being excreted in this way. And you can see the urea goes, water goes, the creatinine and beta 2 microglobulin also goes, but the albumin stays in the blood compartment. I'll just rerun this for you. How it is getting filtered and it is getting concentrated, how the blood gets concentrated. Okay, so this is the best way in which I can show you the convection, and all courtesy to the source that is from the YouTube. Now, coming back to the CRRT modalities, so how do you increase the pressure? You add some fluid along with that, okay? So I will not go into the details of it to confuse you further, but you can see that the scuff versus hemofiltration versus hemodialysis versus hemofiltration. In scuff and hemofiltration, in scuff, there is no solute clearance. It's only used to remove the excess fluid. In CVVH, some level of solute clearance with convection. And in CVHD, the diffusion is also there, solute clearance is also there. But when it comes to CVVHDF, which is hemodiafiltration, it is convection plus filtration. So you have the solute, you have the fluid also that is coming out of your the dialysis machine. Now, when do we usually use these use these technologies, use when it comes to IHD versus SLED versus CVVHD, and what are the principles behind it? As you can see, in intermittent hemodialysis, it's only diffusion, and it's usually done for like 3 to 4 hours. Like our CKD patients on maintenance dialysis, that is what IHD stands for, right? So it follows the principle of diffusion, and it is for 4 hours. And you can see how much blood is flowing through the dialysate during per minute. So nearly 300 to 400 ml of blood is drawn and given to the dialysate into the dialysis machine per minute. Okay, a large volume is taken and given. But when you come to SLED, the slow and low efficacy dialysis, it has a combination. It can be diffusion plus or minus convection based on your need, and it is because it is slow. It is more time consuming. It's 6 to 12 hours it can take, but you can see here the blood flow, instead of taking 400 ml per minute, you have a lesser amount of fluid that is being drawn from the patient. And in hemodiafiltration, continuous veno-vena hemodiafiltration, it is combination of convection and diffusion. And you can see that it is, because it's continuous, it's over 24 hours. But the most striking feature is that only a very small amount of blood is being drawn at a time from the patient to run through this filtration, so that you have enough time. You have 24 hours to run the patient's whole blood through this dialysate to the dialysate machine to to help you with the filtration processes. Now, why is it important? Why have I mentioned the blood flow there? Because in what modality to be chosen for which patient also comes very important. So this is a clinical scenario. I know this is again, kind of a very busy slide, but you can see that one thing that I can easily that you can see on a daily basis is that when patient comes with septic shock, okay, obviously when there is shock, there will be some component of AKI, and they might even need RRT. So when a patient is coming with septic shock, shock means hypotension. The patient already is having low BP. You are giving fluids. You are giving a lot of vasopressors to, bring the BP up. Okay, in such patients, just imagine the patient already having shock. You try and do an intermittent dialysis. You are taking nearly 400 ml per minute. The patient will again go into hypertension. That's why patient crash during dialysis, because a large volume is being taken from the patient's body to do the dialysis, so that the patient comes out of this problem. But when you withdraw a large amount of blood in a patient whose BP is already on the lower side, that results in this hypertensive episodes when you do intermittent dialysis. So this is where SLED and CRRRT comes. So in SLED, instead of taking that whole big chunk of blood altogether, an intermediate amount is being taken, and you have more time to do it. Anyway, the patient is in the ICU or admitted, so you have time, and you can slowly remove all these electrolytes, or correct the imbalances or the fluid. You have over time, you can do it. And in continuous therapy, you can even more do it more carefully without having much consequences. So you can see here as to which in each clinical scenario, which is preferred over what. All right. Now, why should we clinical pharmacists talk about this renal dosing when it comes to AKI? Like I know, I've already mentioned that the recommendations are quite on the lower side. We do not have standard guidelines for AKI, and therefore there was a survey that was done, and this was published in the International Journal of Clinical Pharmacy. All right, and they did a survey for pharmacists. So basically, clinical pharmacists working in a clinical setting, or pharmacists working in a clinical setting, as to how they would dose their patient for SLED. Okay, so this was a very interesting survey that they did, and I've just taken one of the tables that was there in that literature, and you can see how, so each pharmacist, so the number of respondents, okay, nearly out of 20 respondents, for when they asked 20 pharmacists, how would you dose piperacillin tazobactam for your patient in AKI for SLED? You can see the wide distribution of these curves. That means each person said different things. Okay, some people said yes, I would dose my patient 2.25 Q8. Some people said, okay, the most number of people, they said 2.25 Q8, and then some people said they would 3.375 Q8. 3.37 Q6, 4.5 Q8, 4.5 Q6. You can see this variation among pharmacists. Okay, and this is done in a developed country. So just imagine what is the problem with a developing country where the resources are so much lower. So you can see that there is a wide variation among pharmacists, among working clinicians, healthcare professionals as to how to dose these drugs. So this dilemma is there, and that's why we need to understand the pharmacokinetics to make sure that whatever we are giving, we are not underdosing our patients and are also not, intoxicating our patients with so much of drug. And you know that in critical care in ICU, there is so much of physiological changes. There's so much of pharmacokinetic changes when it comes to drugs, and that itself, it's a different talk, not just one talk. Each parameter, augmented renal clearance, in itself is a 1 hour, 2 hour talk. And you can know that in critical care, how the fluid balances, the physiology changes. You know that if there can be some patients can be hyperdynamic, like a young RTA patient coming with a brain injury. They can be hyperdynamic. There can be altered fluid statuses. In organ dysfunction, it's a different ball game. In organ with no organ dysfunction, it's a different ball game. So you can see that the increasing, decreasing plasma concentration, the changes in the volume of distribution in clearance. Like I said, when you have a patient with septic shock, because the BP is on the lower side, the first and the most important thing is fluid resuscitation. You pump the patient with liters of NS, normal saline, and therefore all of a sudden there's so much fluid there. It increases the volume of distribution. So for each drug, it differs. If it's a highly distributed drug, it goes everywhere. The drug goes everywhere. But whereas when you have a drug that has a lower volume of distribution, it just concentrate in some areas. So all these things, we need to understand the kinetics of critical illness before dosing our patients. And you can see that when it comes to organ support, like when it comes to using ECMO or renal replacement therapy, you know that there is increased volume of distribution and increased clearance. Okay, so there can be a very big imbalance when it comes to plasma concentration of the drugs. So uh, this is the reason why we need to know how to dose our drugs rightly. Now, this was another good journal that article that I found very interesting, that antibiotic dosing in patients with AKI, you have to give enough, but not too much. And what I've highlighted there, I'll just read it out loud. Increasing evidence suggests that antibiotic dosing in critically ill patients with AKI often does not achieve pharmacodynamic goals. So, what are the pharmacodynamic goals that we are talking about? Your time dependent, your concentration dependent, how to dose them. All these things for a normal patient we've learned earlier, but when it comes to critical care, when it comes to critically ill patients, to meet these pharmacodynamic goals, it becomes a very difficult task, and therefore contributing to more of the mortality. So, like I said, enough versus too much. So many concerns are there, as you can see in this picture, how increased volume of distribution, the differing protein binding, the clearance, all these, how it can affect. It can easily tip off the balance when it comes to such scenarios. And this is one of the big data that I could find when it comes to the renal replacement therapy. It was done by Jason Roberts and et al., who has the position papers, a lot of position papers coming based on precision dosing. And this was the first study to compare different modalities of renal replacement therapy. All right. So, like the topic suggests, the effect of RRT on antibiotic dose, on antibiotic concentrations. So they basically, what they did was, for each patient who were on an antibiotic, they did the therapeutic drug monitoring, and they understood how much dose is actually going in, how much is being in circulation, and how and this was a multinational study. And like I said, this is the first study that the first study to compare among, like, the IHD versus SLED versus RRT. All right. And what they found was also extremely very fascinating. In meropenem, they did not see much variability. In vancomycin, they had a lot of variability. But when it came to piperacillin, there was a lot of intersubject variability. So for each of these three drugs that we use very commonly, there was so much of variation that was happening. So this is one journal article that I would like all of you to go and read to understand more into how to dose your patients. Now, there are so many factors that you need to consider while dosing your drugs in acute kidney injury. So one, like I said, is the pharmacokinetics. Okay. So what is your the drug that you're having at hand? What is the volume of distribution of the drug, and what is the clearance of that drug? Because that really will tell you how much you have to dose your drug, whether the loading dose has to be given, how to do your how to calculate your maintenance dose, and these are the drug-related pharmacokinetics. Then you have So then you have the solubility, the drug-related other properties like solubility, like whether your drug is lipophilic or hydrophilic. So if it is hydrophilic, what is the importance of having a hydrophilic drug? So like I said, always coming back to the most common example, septic shock patient, like I said, pumped with a lot of fluid. So when it comes to a hydrophilic drug, which means it loves water, so when you give a lot of fluid to a patient or a patient in so much of fluid overload, what happens? The volume of distribution increases for hydrophilic drugs. They just get distributed all across. But if you're thinking of an antibiotic, you have a source where it has to concentrate. Like it could be your kidney, it could be your urinary tract, it could be your pneumonia or your lungs. So when you give a lot of fluids and when you give a hydrophilic antibiotic, the volume of distribution is too much and it can lead to underdosing. Okay. And therefore, you have to be careful while choosing your agent as to how you dose it. For hydrophilic drugs, therefore, I would say for hydrophilic drugs, try and give a higher dose than usual. So this is where we are coming to as to how to make sure based on hydrophilicity versus lipophilicity versus protein binding, high volume of distribution, how to choose the drug and the physiochemistry of the drug. Okay, again, like what is the size of the molecule, whether it is a dialysable molecule or how much protein binding is it for that molecule. All these things really matters when it comes to choosing your drug for the patient and also dosing your drug for that particularly ill patient. Now, like I said, the volume of distribution will tell you whether you need to give the patient a loading dose or not. So the loading dose is related to the volume of distribution of a drug, whereas the maintenance dose is related to the clearance of the drug. All right. So usually, why do we reduce the dose? Because the clearance is not so well. You reduce the maintenance dose, right? But it is important that whenever you're giving a drug which has a loading dose, you must give that loading dose first before decreasing the maintenance dose. All right. So meropenem, you have a patient with AKI. Let's say the patient requiring RRT, requiring IHT. The usual dosing is 500 mg OD or we use Q12H. So instead of giving 500 as a first dose, you have to give that 1 gram loading dose and then subsequently followed by the 500 mg for your patient in acute kidney injury. So there are many other factors like how much is the urine output. This scenario is for a patient who is anuric. But if there is a patient who has more than 1,000 ml of urine produced, I would try to give the patient the maximum dose. I would usually dose the patient if there is adequate urine output. That means the kidneys are functioning to some extent, so the clearance of the drug will happen. If it's a septic shock patient, I would dose the patient as normal, as long as the urine function is there and as long as the creatinine stays stable. And because in septic shock, like I said, it's usually the sepsis that causes the acute kidney injury. So once you correct the sepsis, acute kidney injury usually settles by itself. So initial first few days, if there is good urine output and the creatinine is not climbing on, going on rising, I would still try to dose the patient normally, so that with whatever residual urine function is there, I know that it will not contribute towards the toxicity. So whenever you have a drug that requires loading dose, you remember what kind of patient you are having. Is it a hyperdynamic patient with who is going to have a variation with a higher end of volume of distribution? You have to give that loading dose. And what is the other thing? Like I said, if the patient is going to undergo RRT, definitely elimination is going to be on the good side. Therefore, you have to make sure that you give the sufficient maintenance dose. And like in a dialysis, the effluent rate also is very important. Effluent is the one that goes through the filtrate. So if the effluent rate is higher, you have to give higher doses. Now, it is a very pretty straightforward fact that when the molecular weight is low, the dialysability of that drug is high. Smaller the molecule, it can go through the semi-permeable membrane. But what I want you to concentrate here is the hemodialysis versus hemofiltration. Like I said, there is a pressure gradient also when it comes to diafiltration, and even small to medium-sized molecules can be, pushed from that semi-permeable membrane. Okay. And coming to the protein binding, again, that is a very important concept when it comes to protein binding. You know that you have to classify your drugs based on what kind of protein binding that drug is having and what kind of volume of distribution the drug is having. So, for an example, if it's a highly protein bound drug and you are having a patient with AKI whose albumin is too low, let's say less than 2.5, that is quite, the albumin is quite low, or less than 2 gram per deciliter of albumin. That means there's not much protein to bind the drug. Okay, so you think that that will create toxicity, but what actually happens is that when a highly protein bound drug is given for a patient with hypoalbuminemia, like in AK and all that, a lot of free drug is there in the blood. But the problem is that as long as the patient is on, if the kidneys are okay, the patient will easily excrete those free drug through the urine, and it can result in, subtherapeutic doses. It can cause treatment failure. But if that is a patient on RRT, because of the protein bound nature of the drug, and if these are small molecules, they get easily dialyzed, and therefore all these, because in AK, hypoalbuminemia is something that usually comes up quite starkly, right? It is always there in AK, it always reflects in the albumin also. So that is one thing. And there is one other term called the seeing coefficient, which is the capacity of a drug to pass through the hemofilter. Okay. So the drug with smaller molecular weight and low protein binding, because of the sieving coefficient, there is less chance of, getting filtered out. And now, when it comes to the general dosing guidelines for renal replacement therapy, what you have to understand. So, IHT also, we have most of the data for most of the antibiotics as to how to dose a patient in IHT. And the other thing, like I said, is how to, make sure, know about your protein binding, know about your volume of distribution, and clearance in the hydrophilicity and lipophilicity of the drug. And accordingly, also, you can dose the patient. But something new that is coming in India in a more, in a big way is the continuous renal replacement therapy. Many hospitals are adopting it. Even in Kerala, I know that multiple centers have started this continuous renal replacement therapy. And, what I need you to understand is that in CRRT, it is, why is it done over 24 hours? So that whatever the kidney does, it is in a way trying to replicate rather than doing in an intense 3 to 4 hours. It is more physiological. Okay, it is like how the kidney does, and therefore it is easier to dose when it comes to CRRT when compared with IHT. Excuse me. And Therefore, most of the time, almost full doses are given when it comes to CRRT. So, when it comes to CRRT, not every drug needs adjustment. So, this is a very important slide. You have to think of those drugs that are being excreted via urine, okay, those who are renally cleared. So any antibiotic that are not renally cleared, or less than 25% of it is renally cleared, it doesn't need much of dosing adjustment. Okay, and that is the reason why polymyxin, you don't have a dose adjustment when you compare it with colistin. Colistin has a dose adjustment when it comes to renal failure, but polymyxin doesn't have, because it is not renally cleared. And again, protein binding. If you have a drug that is more than 80% protein bound drug, that also, in a way, sometimes needs to be considered very carefully. And again, lipophilic drug, because when it comes to RRT, most of the patients are on fluid overload. So the lipophilic drug, the volume of distribution is on the lower side, and therefore you might not need to dose it aggressively when it comes to lipophilic drug. One good example that I can easily give you is linezolid. Linezolid doesn't have a renally adjusted dosing for kidney diseases, because it is a lipophilic drug. So this is one of the good articles that I found in one of the presentations. It's more in, it's not actually in English. That's why you can see that some of the, uh, you know, the spelling of these various drugs are different. Teicoplanin has an extra E, linezolid has an extra E. It's more of a French, you know, basis of this one. And you can see that here they have tried to classify the drugs as to which are the ones, as you can see, these drugs mostly, because they are highly protein bound and highly, the volume of distribution is on the high side, they don't need to be on the they don't need to be dosed very compactly. And when you come to low protein bound and low volume of distribution drugs, those are the ones who need a lot of uh, dosing adjustments. Now, the good thing about how new drugs are coming are that, like you can see for cefiderocol, you can see that already the packet insert, the FDA label is coming with that optimal dosing, where you can see that the effluent flow rate, based on the effluent flow rate, I said for the higher the rate, the higher dose has to be given. So you can see that whenever the effluent rate is going up from 0.5 to 5, how the dose has changed from 1.5 to 2 Q8H. So now the good thing is that for new drugs, along with the renal dosing instructions, you even have the instructions for CRRT. And like I said, based on the how to attain the pharmacodynamic targets, again, based on the PKPD parameters also, time dependent, concentration dependent antibiotics also, you have how you can dose them differently. And again, one of the good articles that I could find regarding how to choose when you come with, like for time dependent, concentration dependent, the AUC based dose, AUC based classification of antibiotics, how to give the first dose, when it comes to daily dose, how usually, if you are thinking about augmented renal clearance, how you have to dose them. When it comes to AK, how you have to dose them. And when it comes to CRRT, how you dose them. So one example that I can easily share with you is, as you can see, when it comes to beta-lactam. When it comes to beta-lactam antibiotics, you can see that when it comes to CRRT, almost all the beta-lactam, so meropenem, all your beta-lactam antibiotics, they are usually, they can be given almost as a normal dose. Okay, so that's what I was saying. Because it mimics the physiology more, the CRRT mimics the physiology in a very similar fashion, you can dose them like normal patients. Okay. And there are certain patient related factors as to how sick the patient is, or what is the weight of the patient, how hypoalbuminemia, like I've already discussed, and the role of residual kidney renal function. So just to say that, this was one good study that they did as to recommendation of beta-lactam regimens, which are inadequate in septic patients treated with CRRT. So what you can see is that sicker patients, because they are in shock, they receive a lot of fluids for resuscitation. Therefore, a large volume of distribution. Therefore, large doses are required, and loading doses therefore are absolutely required. In this one, the graph shows that if you don't use high dose initially, if you don't give high dose initially, you won't attain your target. So if you're having a very sick patient, always, like I said, loading doses are extremely important. Always load the patient, and then based on the fluctuating renal and based on the urine output, you dose your patient subsequent days. And one important aspect is the role of residual renal function. This is again one of the interesting factors. Like I said, I think one example that I can easily give you is this population pharmacokinetic study of fluconazole in ICU patients who are undergoing this continuous venovenous hemodiafiltration. What happened was that, because this is anuric patient versus oliguric patients. So like I said, if there is some kind of urine that is being produced, that means the kidneys are functioning a bit, a little bit. And like I said, the three common mechanisms why the kidney function is the filtration, ultrafiltration, the secretion, and the reabsorption. So in the study, what they could show was that fluconazole is a drug that gets reabsorbed. So when it was an anuric patient, when used in anuric patients with the CRRT, the total clearance was much high. All right, a lot of it was being pulled away, but when it was mixed, when the patient had some kind of residual uh, volume of urine there, the drug gets back into the system, and that's how therefore the reason for having to take into account how much urine is produced by a patient who is sick is also important. But one thing that can that can be advocated, and which is coming in a big way, is therapeutic drug monitoring, because we know that uh, interpatient variability is there, and therefore this one dose fits all has to change, and we have to switch on to the precision dosing. And what are the easier things to do? So the first thing that you can do is, finding out what is the frequency of intermittent dialysis and how do you dose your patients. Whether the post HD dose is given, and if a patient is due for the next dose of meropenem and the dialysis about, okay, let the third hour, and the dialysis is about to finish at the fourth hour, you can wait till the fourth hour for the dialysis to finish and give the meropenem, rather than give the meropenem while the patient is undergoing dialysis, and then end up being underdosing the patient. Then how to optimize the pharmacodynamic indices based on what I have talked about so far, the hydrophilicity, the lipophilicity, and like I said, the post HT dose is something that many can easily miss. So a clinical pharmacist being in the ICU, being in the IHD for antibiotic dosing is extremely important, and the timing of antibiotics. Okay, so like in CRRT also, see, on a day, these are patients with so much hyper activities going on. Okay, one day the patient is sick, the one day the patient is not so sick. So how is the patient receiving CRRT for 24 hours, 48 hours, 72 hours, or just one day they have done the CRRT, the next day they are going back to the normal, let's see, watch whether the patient is improving or not. So in each day, the dose adjustment becomes very essential. Therefore, and giving the timing of dosing, timing of antibiotics becomes especially important. And one one of the good references that I could find for the CRRT and even for the SLED is the Stanford Antimicrobial Dosing Guide. So here you can see that for meropenem, when it comes to CRRT, it's the usual dose. So whatever you give for a patient with normal creatinine clearance, you give the same dose when you're putting the patient on a CRRT. And also you have the Stanford uh, dosing guide for your sled as well. So these are the common good references that you can look into when it comes to renal replacement dosing. And therefore, to conclude the presentation, the AKI is associated with so much of mortality, and the dosing of RRT can be complex based on the variation in the pharmacokinetics of the drug and also the patient dynamics. And the different modalities of RRT will have different effects of the drug based on the effluent rate, how long it's done. And therefore, the PKPD considerations are important when it comes to dosing, and TDM has to be the way forward. So with that, I would like to end my presentation. And if there are any questions, I will take that for now.
Thank you, ma'am. So that was a wonderful presentation, very informative. The way ma'am took us from the basics, just dividing and making us understand through the basics and taking us to the higher concepts of topic, and these all of the informations that made us understand it was just not the creatinine clearance and just those dose based adjustments is nothing of nothing of nothing of that kind of uh, or it is more that we should look into the protein binding, or it's more that we should look into the other aspects of when we are considering to renally adjust the patient on dosings. So it was like an eye opener. It is like it's like a complete package for someone to get someone on renal renal replacement dosage adjustments. So thank you so much, ma'am. Moving on with the questions, so it's even in the ICUs, it's bit of a confusion that in septic shock patients, initially we'll go with the loading dose, we'll go with the full loading dose, and after that in 24 hours everyone is fine with giving the full dose. So once the 24 hours is over with giving the full dose, like for most of the antibiotics, we're expecting to give the antibiotics for 14 days or 7 days, or since the patient is in septic shock conditions, we are expected that the patient will be on antibiotics for a longer term. So after the 24 hours, then there comes a panic, or shouldn't we adjust the dose, or that panic always starts. So initial 24 hours, everyone is okay with giving the full doses. So once the 24 hours passes by, then again we'll start getting that confusion of adjusting the creatinine. What's ma'am's opinion on that?
So like I said, I think dosing in AKI can be a bit challenging. And thank you for that question, because in wherever I go and present, this dosing in AKI is something that I always stress upon. That is where we can always, underdose a patient. Okay. So when you're having a drug like meropenem or piperacillin tazobactam, and we know that those are quite, like safe, efficacious drug. Okay, the toxicity is not so much for such beta-lactam category of drugs versus something like vancomycin. We know that it can be nephrotoxic if you give vancomycin a lot. It can be nephrotoxic if you give colistin a lot. So, based on the safety profile, that's one thing that initially you should classify the drug. What will happen if something more goes to that patient, like meropenem? If I give the full dose, what can the you should anticipate what are the things that can go wrong with that patient. If that doesn't worry you that much, and like I said, when it comes to septic shock, which is the most commonest scenario in all ICUs, when it comes to septic shock, it is because of the sepsis, because of the dysregulated immune response, a lot of vasodilatory, a lot of inflammatory mediators causing vasodilation is the reason for the septic shock. And because of this vasodilation, there is ischemia, which leads to acute kidney injury. So if you're clear with that concept, you know that the source of the problem is with the sepsis, with that, infection. So if you treat a patient, like you said, the first 24 hours, you dose the patient fully. Okay, let's say your creatinine is 3 and the patient is having good urine output. Let's say at least the patient is having around 800 to 1000 ml of urine. So you know that the creatinine is 3, the urine output is good. Okay, it's not too bad. It's on the lower side, but it's still good, and you fully dose the patient. You give, your 1 gram QATS that 24 hours. And anyway, because the patient is in critical care, they'll obviously check the creatinine, right? And you can obviously measure your urine output. If the urine output is improving, or if the creatinine is improving, or at least the creatinine is not worsening, that means that the patient, you know, you can continue to give that dose for a longer time. You review it because it's a critically ill patient. Maybe you can review it every 12th hourly. You don't need to do it every day, but every 12th hourly, if you have the resource, you can review the patient. If there is an event of worsening, and if it's a nephrotoxic drug, that is when you have to, you know, cut down on your doses. You come down on your doses and reduce the dose and give. But if it's not that's the case, the creatinine is improving, the urine output is slowly improving, the patient is slowly improving, I would say wait one more day before you cut down the dose of the antibiotic, because the antibiotic is going to be the lifesaver in such scenarios. But when it comes to cholesterol, it's a really difficult question when it comes to cholesterol, because cholesterol itself can cause acute kidney injury and nephrotoxicity. So in such cases, you have to see how sick the patient is, whether you can, wait for at least one more dose and see whether the urine output is improving, whether the patient is improving, and accordingly, based on the clinical effects, also you can taper down or keep the dose going. Is what I would do in such cases.
Okay, ma'am, thank you for that answer. And one more query is, if the patient is in septic shock, but still if it is a culture negative situation, it's we haven't got any cultures positive, but we are empirically escalating the antibiotics, and the patient is in a shock condition. In
Yeah,
culture
again,
negative scenario,
even if you take a culture positive one, the culture will most likely be positive by the third day. So anyway, you have 74 hours before the culture actually comes. So what would you do for those 3 days when you are empirically treating the patient? It is whenever there is culture negative problem, you have to see how the patient is doing. So because you don't know what you're treating, you have to look at the patient and see how the patient is responding. So if the patient is responding, yes, I would still keep doing, the good doses. And I know that it's septic shock and pneumonia is the problem, or UTI is the problem. I know that the infection is the problem. So you would continue to give the higher dose, and you follow them carefully. But let's say you gave the patient meropen and the patient is still having high fevers after 2 days, the patient's NORAD requirement is going up, everything is metabolic acidosis is not settling, all these things if you can see. And that is maybe one way of thinking, maybe I'm not covering something the patient is having. That's You have the antibiotic ladder as to, after 24 hours or after 48 hours, you see whether the patient responding. If not responding, what to hike up, what addition you need to add, or from European, whether you need to think of if it's a patient who had hospital stay earlier, if it's a patient who is at the risk of having a MDR infection or a carbapenem resistant infection, maybe think of ceftazidime, maybe Bactrim, or even colistin. If it's lung, if it's Acinetobacter kind of thing, that scares you. Based on the risk factors, uh, only based on how the patient responds, we can, escalate or de-escalate in such scenarios if it's a culture negative sepsis.
okay, ma'am, thank you for answering that. So the key lies in close monitoring the patient.
Yes.
Yes. So I think we are done with the questions.
All right. So thank you, Swati, for moderating the session, and we have a good lineup of presentations coming up, both in critical care forum and well as in the infectious disease forum. So the next presentation in critical care forum is will be taken by Dr. Eldo Matthew, on hypovolemic shock on 12th April. And then we have the fourth presentation for cycle 2 of infectious diseases, which will be taken by Surabhi on a very important topic as to what the penetration of antibiotics at different sites are going to be. And again, for critical care medicine, we have the year in review for 2023 taken by Dr. Rajan Barokar on the top papers in critical care medicine. And our podcast is also going to be live on April 19th with Nistela will be the host for it, and it will be regarding the unleashing of the transplant clinical pharmacy role in India with Dr. Sudhindran and Dr. Harita, who is a clinical care clinical pharmacist in transplant, along with her professor, Dr. Sudhiran. And again, the infectious disease module in duration, the low hanging fruits, the duration of therapy will be coming on April 20th, which will be taken by Dr. Satyanarayana. So you have a big lineup of good talks, important basic things that everybody would benefit from. I hope that you would join for these presentations as well and enrich your knowledge when it comes to your clinical practice and do well with your clinical practice. So with that, I think we'll sign off.